Hi everyone. Just bear with me. Sorry, I've had to use my phone because my laptop doesn't seem to want to work today. So finally I'm on. So if anybody's still here, good on you for sticking with us. If not, then I'm sure loads of you will come back to watch this on another day. My name's Sharon. I am the VP of Mentoring, and I'm also a practicing dentist. So we are just going to go through the dental stream of the study guide today. So bear with me a second, I'll get the questions up. So Dr. Quinn has beautifully gone through the scenario with you and gone through the medical things, and a lot of the things that she's spoken about also apply to the dental side of things. But some of the questions that I asked specifically, if we start with the first one, so this one was really more just to get you guys thinking about the way dentistry is offered around the world and in the different areas. So as you can imagine, with most medical and dental things in as we say, developed countries, the services tend to be a little bit better. From my research, the proportion, there are about 45,000 dentists in the UK. That serve a population of around 60 million. So on a ratio scale, you're looking at about one dentist for every 1,500 patients. So in Africa, the statistics are saying that there's one dentist for every 150,000 patients. As you can imagine, some places are very, very remote, so people travel miles and miles for dental treatment, and that's obviously going to affect the provision and the skills of the dentist. Now, there are a lot of companies over here that do go over there to train the medical professionals to take out teeth, so that's just increasing the amount of people in the dental workforce and increasing the skills of medical professionals, so that people aren't having to walk miles and hundreds of miles on end just to find a dentist. Their local, let's say GP, would be able to do it for them. As we know, there's the health service here works in terms of dentistry is it has three different arms. So there's primary care dentistry, which is your general dentists on the high street. Then an arm of that is private dentistry. There's community services, which is kind of a bridge the gap between primary and secondary care. And that's kind of a referral service. That's where I work in paediatrics. So we tend to get the children who are higher need, autistic children, children with special needs, children who are especially anxious that your general dentist can't treat on the high street. And then there's obviously secondary care for the increased higher needs and treatment of general anaesthetic, and dental hospitals, which have the kind of things that, once again, both primary care and secondary care, community care couldn't take care of. Then you have in countries like America, where dentistry is completely private. There is no version of the NHS over there, both from a medical or a dental point of view. So everyone pays for their dental treatment. And you may hear in some programs that people are always like, oh yeah, my job includes dental insurance. That's quite a big deal over there, as I can imagine. Dentistry probably costs quite a lot of money. It's quite high revenue. The other thing is, over there, when you are a dental student here and you treat patients in a dental hospital, everything you pretty much do is free apart from dentures. Over there, people even pay for the dental students to treat them, so everything is paid for. So we've actually got it, as much as we moan about NHS dentistry in this country, we've actually got it pretty good. And in comparison to the continent of Africa, the statistics I've read, we obviously have it very, very good. That was this first question was really just for you guys to have a bit of research yourself and kind of stimulate your mind and have look into what dentistry is like around the world, especially if, as undergraduates, you go ahead and start doing things like electives and things like that. It's really good to know how things differ. As you know, a lot of our graduates do tend to leave and go abroad. Australia and New Zealand being very common places that they go to. So if we go back to the scenario itself, it was obviously around Ebola. Now, one of the things with Ebola is you can get bleeding from the mouth. So if we take it down to a clinical scenario, you were a dentist working in surgery, if a patient attended your practice bleeding from the mucosa or the gingiva, how would you manage this situation immediately? So obviously bleeding can be a huge range. It can be from a small trickle, it can be just from after you've brushed your teeth, or it can be quite a lot, and I have seen some very, very bad incidents of bleeding post-tooth extraction. The first thing would obviously be to put pressure on it. It's the same with any sort of bleeding you have in your body, pressure. So get that patient to bite down onto a piece of gauze, keep that there for 5 minutes firm. Okay, don't let it move. Then take it out, have a look. If it continues to bleed, then you need to use some sort of adjunct on top of the pressure. So one of the key things that you'll have available in your dental practice will be adrenaline in the form of local anaesthetic. So squirt a load of that onto a piece of gauze and get the patient to bite onto that. Now, as you know, adrenaline works as a vasoconstrictor, so it constrict the blood vessels that it's in contact with, and help to decrease the bleeding. In a secondary care setting, say, I know this question doesn't ask that, but if you're in a secondary care setting, then you could consider using other things like tranexamic acid, which will help to stop the bleeding, but it's not something I would use. I'd stick with local anaesthetic, and that will help in 99.9% of the cases. You may consider if you've just extracted a tooth, there obviously will be a socket there, and the patient may not have bled a lot at the time, but they are now. So it may be worthwhile, instead of you use what we call local measures. So your local measures will be what we call Surgicel, which is essentially a mesh or piece of gauze which helps the clotting, and then we use a suture over the top, and the suture I like to use a purse string suture. So you essentially, this is not a suturing tutorial, but you essentially do it in such a way where it works like a purse string and will pull the edges of the gum together so as to cause that kind of local pressure. And like I said, is very, very, very effective. Even injecting just some local anaesthetic into the gum itself. I know you might think that, hold on, injecting, surely that's only going to make the bleeding worse, but because the adrenaline's in there, it really does help, and will last a little bit longer than just putting some on some gauze. So as a dentist, actually in practice, there is a lot that you can do to stop that bleeding. There are some certain circumstances where it will not stop. Okay, and that would be particularly if a patient has some sort of contraindicating medical history. So patients with uncontrolled hypertension may bleed excessively. Okay, and that may not be something that you noted. It may not be something that you noted long term. Okay, obviously you don't regularly take a blood pressure from a patient every time they come in. So somebody may say to you they have hypertension, but that hypertension could be 150 over 90, or it could be 200 over 100. So, you know, I mean, that person is 200 over 100, that's very, very dangerous territory, not just for bleeding, for a whole host of other problems. If that patient did not stop bleeding immediately, it would take a very, very long time for somebody to bleed out in terms from a blood from the mouth. People tend to think it looks like a lot, but that's because it mixes with saliva and increases the volume, and it's actually not that degree of blood. But you would need to think about contacting the emergency services in some way. Okay, I actually had this with a patient once where she wouldn't stop bleeding. I took out a very simple tooth at the bottom. She was a 70-80-year-old lady, and as far as I was aware, there was no contraindicating medical history whatsoever. I took her tooth out, she went home, she comes back the next day, bleeding rather excessively all down the front of her top. And it turned out that she was actually on 2 lots of blood thinners that her daughters had neglected to tell me about. So this just goes back to the importance of a really, really good medical history, okay? It's really important that you get all the information you can, especially when you're doing invasive procedures like extracting teeth. So I actually took her in my own car to the A&E department, and then the maxillofacial department sutured her up and got the bleeding to stop. So your next port of call would be A&E, and they will usually stop the bleeding. What is also good to do ahead of time, rather than just taking the patient straight away, is phoning your local hospital and getting in touch with the maxillofacial doctor on call, and they will give you some advice and maybe able to get that patient seen a bit faster. It's always nice to make them aware that you're coming before you do. Okay, it's never nice to just turn up on the doorstep, which is what I did. But having worked in Max for a couple of years, I realised that that was not the wisest decision that I'd made. It's always nice to let them know that you're coming. Okay, so if you've got this patient and say in my circumstance they were initially fit and well, and you take out a very, very simple tooth, took all of 5 minutes, and they come back excessively bleeding, you've got to think about why that is happening. Okay, so in my circumstance it was because the medical history I was given was incorrect, and that's that's not completely their fault. It should have been. I should have. This is the reason why having a grounding in your basic sciences is very, very important, and basic medicine is very important. The daughter said told me that she'd had a stroke, and she was asthmatic and she'd recently had a stroke, and I took that as gospel, and they said she's not on any medication for her stroke. Now I know better, as somebody who's had a recent stroke would definitely be on some sort of blood thinning medication. Now, as far as I remember, I think she was on dual therapy, clopidogrel and aspirin, which are antiplatelet therapies. And those as a combination are really, really bad. People bleed a lot. So if I'd have known that beforehand and would have questioned further, then I could have stopped that bleeding before it even started, by putting in the mesh and stitching the gum up. And that likely would have stopped the bleeding. So medications that are going to cause increased bleeding are going to be your antiplatelets, so aspirin, clopidogrel. There's one more. There's one that people have just after they've had a heart attack, and starts with a T. Sorry, it's completely skipped my mind at the minute, but you can have a look into that one because they bleed quite a lot. And then you've got your anticoagulation, so anti-clotting, which is warfarin is the big one, and warfarin is good and bad in both ways, in the fact that it is very difficult to control a patient on warfarin. There are reversals for it though, so if a patient is bleeding excessively, you can take them to A&E, and they can give them a whole load of things, firstly vitamin K and a lot of other reversal agents that will get the blood to clot back up. Warfarin is used in patients who have atrial fibrillation, so a irregular heartbeat. It's used in patients with a whole host of other things, pacemakers. It can sometimes be used in patients who have just had a pulmonary embolus, that's a blood clot, or DVT. So DVT is a blood clot in the leg, a pulmonary embolus is a blood clot in the lung. There are other medications that you can use called DOACs, and they are your rivaroxaban, dabigatran, I think apixaban is another one. Rivaroxaban tends to be the most common one. The thing is with these, I know a few of them have got reversal agents. Not all of them have though, and I think they are in the pipe work. But if you've got a patient on these medications and they're bleeding quite a lot and you can't stop it, that is definitely to A&E, because they will need to deal with that. And if a patient's bleeding quite a lot, they'll need to replace those fluids that they've lost, take some blood just to check that they haven't lost too much blood at all. If you are still able to get the bleeding stopped, and for some miraculous reason that patient has no contraindicated medical history, is a young 25-year-old, no issues, there's a multitude of other reasons it could be. It could be that there was a blood vessel very close to where the tooth is taken out, and you've just managed to hit the blood vessel and it started bleeding, and that just needed a little bit of local pressure. It could be that the patient has some sort of undiagnosed medical problem. So if you're suspicious, then you should always get in touch with their GP and get them to review them in light of further tests, because it may be that this excessive bleeding is an indication of another problem that hasn't been picked up, you know, a bleeding condition. So, yeah, okay. So what are the possible causes? Yeah, we've done that. So referring to the anatomy, so this is something completely separate from the bleeding. So we know that this medical student had been on a plane to get to her placement, and you may have heard in the past that people tend to get a lot of extra pain when they are on an aeroplane, and it can also happen with deep sea divers, and it's all to do with the pressure shift. So your tooth is essentially made up of the very hard enamel on the outside. Then underneath you've got the dentine, which is still quite firm but not as hard. And then you have the nerve, which is called the pulp. Now the pulp is essentially encased in dentine, and that dentine acts like a room with 4 walls, concrete walls. So when you get inflammation of the nerve, it expands. Okay, just like if you hit your hand on something, your hand is going to swell. Okay, that's just a normal reaction. So the pulp has a tendency to swell, and it has nowhere to go. So the four walls are not letting the pulp expand anymore, and that's what tends to cause the problem with toothache, and that's what a lot of it's about. Now, when you go on an aeroplane or you're deep sea diving, that actually increases the pressure in the pulp chamber, and that's what increases the pain that you get. So that's where you might get people saying that they've had increased pain while they've been on an airplane. One thing I would probably say is a lot of people are a little bit hesitant, and I'm one of those where if a patient is due to go on holiday soon, I think you should, and they're currently asymptomatic, they haven't got any problems, you should probably delay any dental treatment till after they come back, because you don't want them to be on a plane and be suffering with this kind of problem. I can't imagine being on an 11-hour flight to India and having toothache. That would probably be your worst nightmare. So it's a good thing to try and delay dental procedures till after they've come back if possible. If they're in acute pain, then you don't have any choice. You need to do something about the pain there and then. But yeah, that's everything, I think. So I can see that there's currently nobody watching, which is cool. But I'm hoping a lot of you will come back and watch this later. If you do have any questions about what I've said, please do just drop me an email. And I'm happy to answer anything that you have. It's always good to have a little bit more research around some of this stuff, because the bleeding one it could be something that you're kind of very loosely asked about at the time, in terms of just to check that how safe you are to start with. So I hope you've enjoyed it, and I'll see you next month. Take care.